What about different types of patients? We have our so-called poor responders, which I think is where I tend to see more of my patients use this treatment. So in other words, it's the patient, she's older, maybe did treatment before, can't get pregnant, and I see a lot of my patients, more poor responders, go in this direction. This one limited study showed a beneficial effect. Alan, would you say that's where you see a lot of your patients?
More desperate. Yeah.
More desperate?
The more things they try.
Yeah, which kind of makes sense. And here's a study that showed no effect. Here's a meta-analysis that said, you know what, we don't really see a difference in acupuncture. I don't even know how to pronounce this guy's name, El Tuki. This was in 2008 as well. Another meta-analysis taking a look at the same topic. He looked at 13 trials, about 2,500 women. Studies were included that had no treatment or sham, and his conclusion was that acupuncture did not improve IVF outcome. Again, another complex slide here, but this is looking at different acupuncture sites with the different studies, and you can see how there's variation. And so again, I think another problem here is comparing apples to apples. They showed a significant difference looking at these studies when acupuncture was performed at the time of embryo transfer. This is with no sham. This is with the sham, taking a look at these groups. Confidence interval covers 1, so that's significant. This one also barely covers that as well. And this was looking at the clinical pregnancy rate of embryo transfer. And when he or she, I don't know if he or she, but when he put this together, he was using a lot of these articles that they did in that first meta-analysis where they took a look at 7 studies with Mannheimer in 2008 and added one additional study by Craig. And when he added that one study, it didn't reach statistical significance, showing you, whatever you throw in there may not influence your final outcome, and I guess one of the shortcomings of meta-analyses. So anyway, it could not demonstrate a difference in pregnancy rates, but again, when he added this one study by Craig, using the same studies as Mannheimer, but adding this one study, did not show a difference. And this is a slide just kind of to remind me to kind of what Doug was talking about. Some of these publications, some of these so-quote larger publications, looked at intervention at the time of embryo transfer, sometimes 2 days later. Some of these weren't even described in the patients in the studies. Control groups varied versus no acupuncture versus different types of shams, and some showed differences and some didn't. So anyway, we did that. What else? Limitations. We all know meta-analyses have limitations. You have heterogeneity of baseline rates across trials and potential for publication and orientation biases. So we all know meta-analyses have shortcomings as well. So what about blinding studies? Do we need to blind these studies? I would argue that probably not. Subfertile trials in general, where the outcomes are entirely objective, such as pregnancy, blinding either patients or physician is infrequently attempted. So we have a lot of studies in fertility where we don't have blinded studies. Some we do. There was a view of common errors in the design of these subfertile studies, and they didn't even really bring up the point of whether to blind the patients during these studies, so it doesn't appear to be as significant. Shams, that's what Doug was alluding to. They may not be inert, and therefore use of sham as a control for IVF trials with purely objective outcomes may increase the risk of bias, and therefore may be unnecessary to confuse the data. So I would argue a study where you're doing acupuncture, you probably wouldn't want to use a sham, in my opinion. Different types of shams that Doug was alluding to. It could be a non-invasive pricking sham, where you put them at the true acupuncture sites, and these sham needles give the patients a sensation of pricking or penetrating sensation, but the needle isn't going in. Even acupressure has been shown to produce changes, so some of these, again, placebos or shams are issues. Other sham-controlled trials have used shams using real needles at the true acupuncture sites, but used in areas that are not associated with fertility avenues. Other shams would involve needles not directly but near the true acupuncture site. So anyway, long and short of it, you look at these studies and look at the shams and how they're done. There's a large variation. There's actually one study in 2009 about 370 patients that were randomized, either real or placebo, again, before and after transfers, and they showed that the placebos actually had a significantly higher overall pregnancy rate, I think demonstrating that there may be problems with these sham acupunctures. And so also when I'm trying to look at all these studies, there might be certain treatment specifics that we need to take consideration, the length of the treatments, the variation in specific points as we've talked about, and there doesn't appear really be consensus amongst the acupuncturists what sites to use. And then also there are obviously differences in the acupuncturists that are performing this, some probably better than others. And none of these studies really break it down into what happens if we do a single versus a double embryo transfer and look at acupuncture. What about patients less than 35, greater than 35, BMIs, fertility diagnoses? In order to really kind of figure that out, we probably would need to do individual patient data meta-analyses to really answer these questions, which I don't think we're going to see with this. Powers of these studies, very rarely did I see any powers of these studies. I think the studies were fairly small. And then we need to also take into account where these studies are being done. For example, in Germany, there's a protection law where you could only use 3 oocytes. So that might limit the conclusions in studies in various countries. So I think at this time, the use of acupuncture as a routine adjuvant to IVF cannot be necessarily advocated, although there's little evidence to suggest harm. Having gone through IVF myself with my wife, I'll be honest, we did acupuncture. So I know I kind of said all this. And so even myself, after drawing scientific conclusions, I think if you kind of look at your own particular situation, sometimes you do try to think outside the box when you're fourth and long. I think the main thing to kind of keep in mind, is it going to do harm? Probably isn't. Although it may not have any truly beneficial effect based on what we know, I think there are certain situations when you're in that situation fourth and long. I know some of you in this room have been through fertility treatments as well. You really start thinking, what else can you do? This is going back a few years, of course, and we have a little more literature on it than we did back in those days. But I can see why patients would want to do it. And so I don't think I'm going to be really necessarily looking at my patients in the face and say, don't do acupuncture. I think if they want to do it, I really don't think there's that much evidence to suggest that it does harm. And even though I don't think it's really necessarily going to help them, I think if I highlight that we don't have the evidence to suggest it's going to be helpful, if they understand that, as opposed to just saying, listen, you need to do acupuncture, you are going to get pregnant if you do this, I think that will lead the expectations to the patients to at least know where the science is, and then they can make those decisions. The other study that I'd really like to see would be if we take a look at, do Doppler flow and look at PIs, and do larger studies showing maybe decreased blood flow to the uterus, and see if acupuncture can possibly help those patients. That might be a group of patients that may benefit, but again, I don't think we have the evidence to really necessarily support that. So hope I didn't confuse you more than clarify, but I know this was when I was looking through this stuff, it's just all over the place. But I don't think the evidence is really there to say, yeah, this is necessarily going to make the difference. Because one of my problems with some of these acupuncturists is, it's a business. And they're selling maybe $500 worth a month of herbal stuff. And I don't know enough about herbal stuff, so I'm not even going to go there. But I don't know what's in that. So my patients that go through treatment, I'm like, no herbal stuff. And so they'll say, oh, what acupuncturists are you seeing? And and then I'm like, yeah. And then herbs, I'm like, no. So the acupuncturists that work with my patients, they know no herbs. And the other thing is, I've had patients go to, for example, to acupuncturist, and the acupuncturist is going to say, you know what about my husband? Oh yeah, that's a great idea. You both need to do it. And I'm like, okay, whoa, Well, what advice are they giving? I had one acupuncturist that had a miscarriage, and she's doing the pulse. Again, I don't know enough about it, but they do this pulse thing, right? And then she's saying, and she's going, hey, you caused the miscarriage. I'm like, come on, really? Letrozole, aromatase inhibitor.
Yeah, right.
There's Femera, which is out there. We've been using that for years and years. I started using it, thinking, okay, that's a good alternative to Clomid. In theory, an aromatase inhibitor will decrease endogenous estrogen. The brain will say, oh, where's the estrogen? and then you secrete FSH, LH to stimulate the ovary. So that's kind of how the mechanism of action is. The question is it any benefit compared to Clomid? Not really. And then about 4 or 5 years ago, there was a publication suggesting that there was a higher increased chance of congenital malformations. We got a letter from, I think it was Aventis, I can't remember who it is, but anyway, saying don't use it in reproductive age women. So I kind of pulled back on it. Even when I use it now, I have patients sign a separate consent form for that because of that study. I don't really think there's a difference. The head-to-head studies don't really show a difference. I think it's more of a shtick. But possibly if you have somebody that you put Clomid on, you have a thin endometrium, you can use letrozole. The downside of letrozole, instead of maybe on average having 2 follicles, you have 1. So I think that any advantage to the endometrial effect is counterbalanced by only throwing out 1 egg. So I think you can do it. I don't do it unless the patient asks me, hey, can I do Femara? I'm like, yeah, sure, why not? Alan, do you use it much?
Same reading now, we did initially. You didn't use tamoxifen.
Right.
But stopped all that for the reasons you just mentioned. Yeah.
So, any other questions? Well, thanks everybody for coming. I really appreciate it. Thank you.